Hey everybody, welcome back to the ECG channel. My name is Reed, and don't forget that you can follow along with this ECG down in the description below. There's a linked PDF document that's this document exactly, so you can make your own notes, save them for later, and otherwise don't forget to like this video and subscribe to the channel. So let's jump into it. So the first thing I like to do is look at the forest and get an idea of what's going on with the rhythm. And so maybe look down here in lead 2, and I see I've got a narrow complex rhythm that seems to be pretty regular, kind of beating along, and I get this early beat. So we've got an early beat, it kind of breaks the cycle. We get a little bit of a pause after, and then we see the resumption of our normal rhythm. And then that same pattern seems to happen again with an early beat and a pause. So we'll kind of work through those early beats, what's going on. My rate here of the normal beats, see this QRS lands on a solid line, so maybe 300, 150, 100, 75, 60. So just faster than 60, maybe 63 beats per minute. Okay, so that's normal. And it appears that I've got some sinus, or at least some P waves before my QRS complexes, so that's reassuring. Let's evaluate those P waves. Those P waves are upright in lead 1, and if I look in AVF, all the way over here, they're upright in AVF, so it tells me that my P waves are going down and to the left, which is what sinus P waves do, so it tells me this is a sinus P wave. Next thing to do within the conduction system is for my AV node to capture that signal and to delay it for 120 to 200 milliseconds, and so that would be my PR interval. So my PR interval, if I measure it, I would say it's right at the upper limit of normal, right? My PR interval, I would say that it is 200 milliseconds, so just on the upper limit of normal, but that's only for that one beat, so we need to make sure that it seems to stay the same, which I would say it does, right? My PR interval stays the same, and I don't see any P waves throughout that don't have QRS complexes, right? That's important, right? Just because this PR interval is normal doesn't mean that every P wave conducts to a QRS. So you gotta scan through, scan all the way through, and make sure, right? Make sure that these pauses don't have P waves that aren't being conducted, right? Because that could explain your pause. You need to have an approach to these pauses that is integrated into your general approach to ECGs, right? And so I probably should have gone over that a little earlier. Maybe what are some thoughts on these pauses that we can look out for? We could have a sinus node pause. We could have AV block, right? It could be all sorts of other reasons, right? Those are probably two of the more common reasons. And so we could have premature atrial or premature ventricular contractions, right? That can lead to a compensatory pause. So, all right, so we looked at our AV node. Now we're going to look at our QRS complex. Our QRS is narrow. It's less than 120 milliseconds. QRS is upright in lead 1, and it's upright in AVF, which tells me that the axis of ventricular depolarization is down to the left, which is normal. That's good. And you can see I've got good R wave progression. Small septal R waves in V1, V2 that grow to become dominant between V3 and V4 and maintain their dominance in V5 and V6. So ventricular conduction looks great in this patient. And then our QT interval, right? Usually I'll just kind of go in between two R to R's, look at the midway point, and I see that this T wave ends by then. So that's normal QT interval. And then I look for pathological Q waves and ST and T wave changes throughout. That would tell me if I have any evidence of a previous myocardial infarction. Maybe you could say that this is a pathological Q wave here in lead 3. Right? It's a pretty deep Q wave, so maybe this person has evidence of a prior RCA or inferior infarct. Right, we know the right coronary artery kind of supplies that territory, but you can correlate that clinically. Otherwise, I don't see any active ST or T wave changes that should be worrying regarding like active ischemia or infarction. So now let's turn our attention to these early beats. Something about these early beats is that they are narrow complex, right? The QRS complex looks exactly the same as our previous ones. So that makes me think of either 1, a premature atrial contraction, or it's 2, a premature junctional contraction, right? And I would say even something that you need to do is, right, you need to always make sure that this doesn't have anything to do with AV blocks, right? So what if this person had like an atrial tachycardia where they just weren't conducting any of these beats that were in between, and they finally conducted one of them, right? But I don't see that. I don't see evidence of atrial tachycardia. So really we're going between PAC, PJC, So next thing we need to do is we need to look for a P wave in front of this narrow complex rhythm, right? Because we know that if it's narrow complex and it looks the same as normal, it's because it's going down our His-Purkinje system. And so I know that if I could find a P wave in front of it, then I can tell that this is a premature atrial contraction. So what do I see? Right there, I see a little P wave. Right, and you can compare it to the previous T wave, which we don't see. So I see a little P wave, right, and you can see it here, nice P wave. Something interesting about this P wave is that if you look at the PR interval, it's a little bit longer than the normal PR interval. And so that's a really cool finding that the AV node has something that's characteristic of decremental conduction. And decremental conduction really just means that the AV node, the more rapidly it is stimulated, then the worse it performs, right? And it actually does that as a safety mechanism to keep us alive if our atria goes into a tachyarrhythmia, like AFib, right? And so that PAC is occurring early, and so in that sense, it's stimulating the AV node faster. And so that's a PAC, and you see the AV node function is a little bit worse with just a slightly longer PR interval, and that's normal. And if you look over here, we have the same thing, right? We have this narrow complex premature beat with a premature atrial contraction that occurs before it, right? There's our PACs. So these are premature atrial contractions. And so we'll put this all together. What do we have? We have a sinus rhythm at a rate of 63 beats per minute. We maybe have some evidence of perhaps a prior inferior myocardial infarction, as evidenced by this Q wave in lead 3. And we have 2 PACs. So I hope this video helps. If you have any questions, throw them down in the comments. And if not, thanks so much for watching, and have a great rest of your day. Take care.